Okay, so we'll go ahead with first question. So in NRP edition, 8th edition, what do you mean by short form warm DSPS? Put your answers in chat box, please. In a recent NRP guideline, what is mean by warm DSPS? Please put your answers in chat box. I'm not seeing any single answer here. Is everybody awake? All fellows are awake?
Sir, I think you are answering in the chat box, in the question and answer.
Okay. I should see in question and answer. Okay. Yeah, few people. Okay. People have started answering now. Few people have answered dry stimulate position suction. Most of them have answered rightly, which is dry stimulate position and suction. Okay, so in new NRP, see, I have attached here a prefix of new arrival. See, there are new few changes which has arrived in this new NRP guideline 8th edition in 2021. So this is first we have to warm the child, then means put under the radiant warmer. We have to dry and remove the wet linen. D stands for dry and S is stimulate. Stimulate, there are the changes has happened in the form while stimulating the child. Previously, the rubbing of the back as well as flickering of the soles of the child were advised, but now rubbing of the back only 2 times it has been advised. So that enough stimulation is needed for that child, and we should not rub it more, or you should not flicker or give slaps over the soles of the child. Then positioning wise, it has been same, that is sniffing position, and shoulder roll should be used if large head is there. Then suction only if needed. It's not that routine suction of mouth followed by nose is done. Suction is only done if visible secretions are there, blood is there in the mouth and nose, meconium is there, and before starting positive pressure ventilation, if you see obvious secretions are there in the mouth, at that time only suctioning is done. So this is warm DSPS. Now second question is, you are doing resuscitation of a neonate and a situation arises where you have to use medications, and in the medication you planned as a chief intensivist to use adrenaline. What dose, preferred route and flush volume of normal saline will advise to your assistant to prepare and give it to the child? I'm waiting for answers in question and answer box. So while resuscitating a neonate, what dose of adrenaline you will advise to prepare your assistant to prepare that, and what volume of flush volume should be prepared, and what is the preferred route of administering that drug? People have started writing. One answer only had come. Jis Jolly has answered. Please, few of you again answer so that I can start explaining. Shraddha also has answered. What is the preferred route? Route nobody has written. Jis Jolly has written the route. Yes, now answers are coming right. One person has written 0.2 mg per kg. One has written 0.1 ml per kilo. Most of you have written 0.2 ml per kilo. Somebody want to answer? Chalo, we'll go ahead. So, sorry. So these are the changes which has happened as compared to NRP 7th edition guideline to NRP 8th edition guideline. So preferred route is IV umbilical line, intravenous umbilical line. So the dose is 0.1 to 0.3 ml still, but for avoiding confusion, they have made it 0.2 ml per kilo. If 3 kg baby is there, 0.6 ml of adrenaline, which is diluted to make as a dilution 1:10,000. Means what you have to take 1 ml of adrenaline and 9 ml of distilled water or normal saline you have to take, so that it will be, means the preparation available is 1:1000. So it will be diluted to 1:10,000. And that flush should be flushed through umbilical line, and the flush volume after giving adrenaline bolus is 3 ml of normal saline you have to push, so that this volume is enough to reach the drug to the heart. So that's why this volume is used. Now another changes are there, like if you are not able, or if you are not, if while the time is there to put umbilical line, so you have already intubated the child and you want to give adrenaline through endotracheal tube, you can try. The dose is 1 ml per kilo, means if 3 kilo baby is there, you can give 3 ml of adrenaline to the child. And if first dose is given through endotracheal tube, then one should consider for disregarding that dose, and you should consider umbilical venous dose as the first dose of adrenaline. And how frequently we have to repeat? We have to repeat it every 3 to 5 minutes. Okay, and you have to continue means CPR or complete resuscitation after stoppage of heart or no signs of life for at least 20 minutes. Previously, the guidelines were till 10 minutes. Clear? So we'll go ahead with third question. So first two I have taken about NRP guideline. Now third question is, identify the equipment. What are the indications of use of this equipment, and name one of the metabolic complication of this use. So identify this equipment and what is the indication of use of this equipment, and tell me the complications of use of this equipment. One metabolic complication. Nobody is answering. I am waiting here. Chalo, people have started answering. So it is one person has answered. Shraddha has answered. So, complications has been written as hypotension. People have written this equipment as INO delivery system. Indication for use is PPHN. Complication has been written as intraventricular hemorrhage. Rahul has written methemoglobinemia. So the machine name is nitric oxide by GIS. PPHN is the indication. Then methemoglobinemia is the metabolic complication. So almost all of you have written correctly. So let me explain few things. So this is inhaled nitric oxide delivery system. So basically this yellow shoulder with white body is a nitric oxide, that is INO. So the two cylinders usually are there in this machine, and from there the connection goes back, and from here this side these two pipes which are INO delivery, one line will be there which is attached to inspiratory limb, and another will be NO2 measurement line, and this actually connected to a ventilator, and how much nitric oxide we are going is seen here. So I know you are going to see here, we usually start from 5 ppm and we maximally go up to 20 ppm, and nitric oxide also is measured here, the value comes here, so it should be less than 5 only. And the metabolic complications associated, so basically the indication for use is pulmonary hypertension, which is very high, and you are not able to control the pulmonary hypertension by other measures, then this is the last measure which you can consider for use as the ultimate treatment. The as compared to other medications which have a systemic complications of use for PPHN, such as systemic hypotension. So one of you has written that the complication of nitric oxide is hypotension. No, it is the advantage of nitric oxide that it never causes systemic hypotension. So nitric oxide is the drug of choice for avoiding systemic, because systemic hypotension has happened, means SVR has reduced, then again right to left shunt is going to increase, and that is going to worsen the PPHN. So this is the drug of choice for pulmonary hypertension. When no other drug is useful, this nitric oxide is useful. So it has been taught that if you start nitric oxide and baby doesn't respond within 30 minutes to 1 hour, you can consider that it is a nitric oxide non-responder. And then things you have to move on to ECMO and that. So the one most important metabolic complication to be monitored when the baby is on nitric oxide is methemoglobinemia. And whenever we start nitric oxide to the child, we keep the antidote ready in the baby's medication tray, that is methylene blue. Okay, here we'll go ahead. So this is a history. No, this is actually the indication we have written here. So pulmonary hypertension, where OI is more than 25 is considered as indication for that. So now we'll move on to next question 4. So which is this equipment? What are the best sites to measure? What is its principle, and when this machine is most useful? I think people are answering very well. So I'm expecting all should answer this correctly. No answer had come till now. What is this equipment? What is its principle? Then where it is to be used, means what is the most important site where it is to be used? So answers are coming now. People have answered it as a transcutaneous bilirubinometer, or TCB. Then the site of use, people have written it as a sternum or forehead. And where it is more useful, people have written as the babies in who are gestational age is more than 35 weeks and before discharge. And the answer coming as TCB, screening for bilirubin level over the sternum. Then most of you have written as sternum. Then in term babies, it is useful. Any bilirubin value where it is useful, or the bilirubin value over which it is of no use, or its accuracy decreases. "35 weeks, forehead, and transcutaneous bilirubinometer. So before discharge, most of you have written. So here one answer had come that more than 15 milligram per deciliter is of less use. So that less than 15, few have written less than 13. And few have written that accuracy decreases as phototherapy is started. So few have written that more than 14 milligram per deciliter, there is no use. Now let me answer. So now this is a TCB machine. Here what you are going to see is the screen. Here is the button to switch it off and switch it off. And here this is the transducer where you have to keep on newborn's body surface. So this transcutaneous bilirubinometer is used for non-invasive measurement of bilirubin in baby. So the most common site or most accurate or most studies are there over the forehead followed by sternum. Now what principle it works is, it sends some means actually rays, and that is reflected through the bilirubin transcutaneously, and the difference between the means spectral difference between these rays is measured, and basically the bilirubin is shown on the screen. So actually what we used to do is we used to take the three readings, and average of 3 is usually taken, and this machine is most useful when the bilirubin values are less than 13 milligram per deciliter. So if the bilirubin values goes more than 13, 14, its accuracy decreases. And again, accuracy will be less if baby is under phototherapy. And we are checking that because photo reduction has happened and skin blanching has happened. And because of that, bilirubin value will be of no use when we start phototherapy. So other measures are there to use transcutaneous bilirubinometer in babies who are under phototherapy, use of patch and that. So we can consider to overcome that. Okay, we'll go ahead. So this is a clinical history. 38 weeks plus 2 days child, 3 kg. And this is a male child at day 1 of life, referred from pediatrician at periphery with bradycardia. In NICU, when the baby was attached to a monitor, baby's heart rate was 40 per minute, capillary filling time was 2 seconds, and blood pressure of the child was systolic 54, diastolic 37, and mean was 44 millimeter of mercury. Following is ECG trace. So this one is the ECG trace of the child. So my question is, what is ECG diagnosis and what is the probable clinical diagnosis of this depending on clinical history and ECG, and what is pathogenesis of this disease, and what is line of management. So this is a term neonate, came from periphery at day 1 of life with history of bradycardia, referred by a pediatrician, and ECG trace is in front of you. And now you are going to answer what is the diagnosis, what is the ECG diagnosis on that. Answers started coming. One has written AV block, congenital heart block by Jaya. Then she has written neonatal lupus is the cause for this disease due to antenatal nodal involvement because of lupus in the mother, and permanent treatment she has written is as pacemaker insertion. Most of you have written maternal SLE, complete heart block, neonatal lupus, then heart block type 2. Chalo, let me answer you. Let me explain what it is. So this is first I will tell you about ECG. So this is the P wave, this is QRS, then this is the P, this is P, then QRS, then these are the two P waves, then QRS, then three are this is T wave, these are two wave, these are two P waves, and this is QRS. So this is 2:1 block, and basically this is a congenital complete heart block, and this heart block most commonly in a newborn baby is secondary to maternal SLE, that is neonatal lupus. And in that, basically baby is going to have other features also. A baby is going to have congenital heart block of neonatal lupus, such as rash will be there, then some WBC and platelet changes will be there. What is the common pathogenesis for that? Mother produces anti-Rho and anti-La antibodies, which act against baby's pacemaker, as well as SA node and AV node will be damaged, and sometimes AV node is damaged so that AV node takes over, and so that heart rate of the child is less. Few of the SA nodes only electric bits are conducted. That's why this 2:1 conduction or 3:1, 4:1 conduction will be there, or complete discordance can be there. And line of management in this child is immediate management is you should consider for medical management of the child to improve the heart rate and to decrease chances of CCF or improve the peripheral perfusion with oral medicines or IV medicine. So previously oral medicines means sympathomimetic agents were not available. Now they are freely available as OSCE prenaline. Previously, when we used to do our DM, only isoprenaline was available. Orciprenaline is very means you will get in Indian market, and you can use orciprenaline also. So the pacemaker is the definitive management, but the pacemaker insertion definitive management is having certain basically criteria to be fulfilled before inserting that, and that will be for lifelong. We'll go ahead. So this is a case scenario: 29 plus 2 weeks, 1 kilo baby, appropriate for date, male neonate at 3 hours of life. So maternal details are she is having PTPROM for 28 hours, foul smelling per vaginal discharge was there. Her temperature was 38 degrees Celsius and her TLC count was 17,800 per cubic millimeter. And she received intrapartum antibiotic and last dose to delivery interval was 2 hours prior. And baby details were temperature was 36.8, breathing spontaneously, and respiratory rate was 47 per minute, CFT of 2 seconds, and MAP of 32 mm of mercury, heart rate was 140 per minute. My question to all of you is, should antimicrobials be started? And if to be started, please justify objectively. How much time is remaining, ma'am?
Sir, actually, the thing is up to 9:45. So,
Okay.
how many more questions are there, sir?
Two or three, ma'am. I will fast finish that. Huh?
Yeah. Okay.
Should I will complete 10. Huh?
Oh, okay.
So any answers had come in?
No
answers started coming. Yes, we should start antibiotic being foul smelling discharge is present. Yes, we should start at that being clinical chorionitis is there. So see, I told specifically objectively you tell. So if you have written as a triple I criteria and in early term. So basically what I wanted to focus it here is you should know about the perinatal scoring. And see, there should not be a difference between the two consultants to start and not to start antibiotic in this child or antimicrobials in this child is that the perinatal score, as I have mentioned, more than 7 is there. You should start empirical antibiotics, send culture to the lab and wait till the culture comes. And then you can consider for modification of your decision. If the score is 0 to 6, monitor the child properly in all sense. And if you feel clinically also that baby is going in deterioration, then you can consider for starting antimicrobials. So in this baby, the score is 12. So antimicrobials were started. We'll go ahead. So this is the PDA view. Now tell me, so actually, how you are going to find out this view, or what is the best PDA view, and what are the eco criteria to diagnose that it is hemodynamically significant PDA? Please answer it fast. We have to finish it in next 5 minutes. You people might be doing neurosonography, lung sonography, and brain sonography during your fellowship program. I presume that, and I intentionally put such question in front of you. So this is bidirectional flow. Someone has mentioned, Wazid has mentioned. So which view is, so how you are going to find out the PDA view? Ductal view, okay. LAO ratio, okay. See, hemodynamically significant PDA is PDA size more than 1.5 millimeter. Then LAO ratio more than 2, E by A ratio more than 1.5. It is usually considered that it is hemodynamically significant PDA. We'll go ahead as time is less. So if you're doing lung ultrasound, you can tell that, is it a best tool to diagnose pneumothorax? Tell true or false. What are the diagnostic features of pneumothorax on ultrasound? My first question is, pneumothorax can 100% of the time be diagnosed, means very good sensitivity and specificity for lung ultrasound to diagnose pneumothorax, whether true or false? Tell me yes or no. Yes. So lung ultrasound is having 100% sensitivity and around 100% specificity to diagnose pneumothorax. So As you might be doing lung ultrasound, I will not go in a detail. So in case of pneumothorax, you are going to find such kind of stratosphere sign or barcode sign if pneumothorax is there. If you are putting M mode in pneumothorax, and you are going to find normal such kind of sea and sand kind of picture if there is no pneumothorax. On the left hand side, you can find that there is absence of B line and more A lines will be there in case of pneumothorax, and lung points you are going to find, and there is absence of lung sliding. If these signs are there, then definitely pneumothorax is there. Now this is, I think, last question. What is this diagram and what it is used for? So people have started answering. It is a forest plot, correct? It is a forest plot, and it is used for assessment of meta-analysis. So in short, I am going to tell you that these small rectangles, solid rectangles, are relative risk of each these study groups, and they are usually chronologically ordered, and summary of all this is will be shown by a diamond, and the ends of diamond indicates the confidence interval, and the lines of this square or circle show that these are the confidence intervals. So the narrow the confidence interval or onto the one hand side indicates the it's more significant. So thank you. I tried to cover almost all the things. I think this is the last slide. This is the 10th question. So what is this investigation and what is the diagnosis, how you are going to treat this problem, and what are the long-term complications? This is my last 10th OSCE question. What is this investigation? MCU, correct. So this is micturating cystourethrogram, and here the diagnosis is posterior urethral wall, meaning you are able to see some part of the posterior urethra is dilated. You are going to treat it with fulguration by urethroskopy, and one should, while counseling the parents, why I have put this last question, because what is the long-term complication of that? See, posterior urethral wall is a correctable thing, but even if you treat properly, even if baby's creat and urea comes to normal, baby's renal function comes to normal, 1/3 of the babies we are going to develop CRF in their adult or old age life. So you should always explain that 30% of the babies are going to have some kind of problem in future. Okay. Here, thank you very much.
Thank you, sir. Thank you for covering so many topics, and I hope all the participants have gained the knowledge out of this and will practice the same. And ma'am, can we end the session?
Yeah, I wanted to offer my special thanks to Dr. Sandeep. I think your keys were fantastic. And please do share it with the chapter, because we are creating a bank. And for the students, we must say that many of the theory paper questions and things may be taken from this bank and from these. So please do pay attention, and thank you very much. Please do share, and thanks everyone for joining on this first day. And Dr. Sandeep, please do mark them and share the marks with the study chapter. Thank you. Thanks, Anjali, and good night.
Thank you.
Good night, everybody.
Good night, everyone.